Good morning or good afternoon, depending on where you are. My name is Harumi Riley, and I would like to welcome you to the second webinar of our Blueprint webinar series. Our series title is Every Step of the Way Through the 1,000 Days, and today's webinar is entitled Improving Community Health Through Continuity of Care in Chest Breastfeeding Support. We value your time, and we hope you leave here today with some new insights and eager to advance continuity of care in your community. Here's a bit about us. NACCHO advances the work of local health departments and its community partners to create healthy, thriving communities. NACCHO supports efforts that protect and improve the health of all people and all communities by promoting national policy, seeking health equity, and supporting local public health systems. We have several different public health programs at NACCHO to help advance our mission. The chest breastfeeding program falls under the MCAH, Maternal, Child, and Adolescent Health portfolio. We have tons of resources developed through this past 7 years, and we have assisted over 100 communities to implement chest breastfeeding projects. You can access journal articles, capacity briefs, webinar recordings, and much, much more through our website. Most recently, we launched the Continuity of Care in Breastfeeding Support Blueprint, and that is what this current 8-part webinar series is all about. NACCHO Chest Breastfeeding Project focused on the unique work in public health breastfeeding. We understand chest breastfeeding as a matter of collective responsibility and not only as an individual choice that parents make in a vacuum. We support communities to enable the healthy choice to be the easy default choice where people live, work, play, raise, and feed children. We believe it takes the whole community to enable chest breastfeeding to be a feasible choice. We are currently in our year 4 of the Reducing Breastfeeding Disparities Through Continuity of Care project. This project is funded by CDC, the Division of Nutrition, Physical Activity, and Obesity, but the views represented within the blueprint does not necessarily represent those of CDC. We also want to acknowledge that the content of the blueprint is a result of inputs from many, many individuals, and it's also supported by evidence-based research. Finally, we want to state that today's presenters have no competing financial interests to disclose. Here's our continuing education information by watching this session live or the recording, and we will be sharing the recording with all those who registered. You are eligible to receive these continuing education credits. So stay put, we'll share more information on how to get those credits at the end of the webinar. Here's our learning objectives for today. We hope that by the end of the session, you understand how lactation is a fundamental health promotion strategy. We hope you learn how some community lactation assessments are conducted. You're able to identify at least one key partner that is uniquely positioned to help advance continuity of care, and how partnerships are essential to establish continuity of care because no one can do this alone. So here is our packed agenda for today. I'm so very excited because I think we truly have built a rock star speaker panel for this session. I am going to just kick us off by providing a background on recommendation 1. Then I'll turn it over to Jolynn Dowling, who has so much knowledge and experience in the topic of lactation as a health promotion strategy and have authored and co-authored many journal publications and textbook chapters in this topic. She currently teaches at the School of Nursing at Wichita State University, and I'm sure her students are so lucky to have her. Next, we have another estimate professor and also associated dean at the George Southern University, our dear Dr. Nandi Marshall. Nandi leads the breastfeeding continuity of care work for the CDC REACH grant in Savannah, Georgia, since 2015. And finally, very excited to hear from Allison and Brenda from Jefferson County and Conectando in Colorado about this critical partnership with emergency response operational managers and their very authentic community engagement to co-create solutions that actually work for the families, right? So as you see, the speakers have contributed invaluable resources to the field. We'll post their bios and recording link to this webinar in our website. We'll close the Q&A with the Q&A. So please submit your questions throughout this presentation using the Q&A box. So as I mentioned, this webinar series is about the continuity of care in breastfeeding support blueprint. So here's a quick overview of the blueprint process for the past 3 years, right? The rationale for the blueprint is that we all know most infants start off breastfeeding in the United States, but rates quickly drop after birth, especially for families of color. There was no comprehensive pathway or clear structure outlining how to continuously and equitably support families in communities to ensure they reach their infant feeding goals. Like, for initiation, there's the baby-friendly hospital 10 steps. So in the fall of 2018, NACCHO and USBC reconvened the continuity of care constellation to share experiences, provide inputs, and basically more than 100 professionals from the field contribute thoughts that became the 7 recommendations for the blueprint. So those recommendations are tailored to local organizations and focuses on strengthening local health systems to build a lactation safety net so families do not fall through the cracks. We launched the blueprint last August during National Breastfeeding Month, and you can download the blueprint from this link here if you have not done so. If you participated in any of the surveys or any of the meetings for the blueprint, would like to thank you again. And let's quickly revisit the continuity of care framework concept, right? The continuity of care framework exists for decades already in many other healthcare fields. Continuity of care is proven to optimize quality of care and is cost efficient and effective in reduced healthcare costs. So this image you see here is an adaptation from continuity of care in primary care, and it reflects the clinical side of continuity of care in lactation support. So on top, you see communication and collaboration among care providers. In the middle, it's the medical records of the family history traveling together and shared from one provider to another. On the bottom, you see the interactions that should be family-centered, respectful, and unbiased. So here's the concept that the continuity of care constellation developed, that continuity of care in chest breastfeeding support is achieved by consistent, collaborative, and seamless delivery of high-quality services for families from the prenatal period until no longer breastfeeding. Continuity of care results in transitions of care that are coordinated and fully supportive of families throughout their chest breastfeeding journey. So as you see here, the continuity of care framework focuses on various aspects of clinical service delivery and the transitions of care among care providers. And to a lesser extent, focuses on the health system infrastructure. So although clinical care and clinical partnerships are critically important, public health involves far more than direct care. Public health works on improving the community context, so the healthy choice can be the easy default choice. So basically for other healthcare fields, continuity of care means mainly the communication, coordination of services and providers. But within lactation support systems, there are so many players that influence this chest breastfeeding journey. As you can see here in this local health system diagram, each of these community stakeholders has a role in continuity of care to ensure that families have consistent, continuous access to supportive environments, systems, and policies. So while ensuring seamless transitions of clinical care needs to be approached at the individual provider or organizational level, ensuring that consistent availability of supportive environments requires an upstream community-wide approach, focusing on systemic solutions to community issues rather than trying to improve individual behavior one at a time. So the continuity of care approach aims to create a lactation safety net in the community so families do not fall through the cracks when transitioning from and to the hospital, from a provider to another, when joining a child care facility or returning to work, or really anywhere across the first 1,000 days. There are many locations and providers where breastfeeding can be promoted, taught, and supported. But currently, what we see is that there is a disjointed approach to continuity of care. Often programs and stakeholders within this local health system operate in silos without awareness of or relationship with others that provide similar or complementary services in the community. So establishing these linkages is necessary to strengthen collective capacity to address structural barriers and the continuity of care breakdowns that contribute to inequitable breastfeeding rates. So here are the 7 recommendations. We're not gonna read all those, but these first 4 are related to improving the community infrastructure. And today we will discuss recommendation 1 that relates to integrating chest breastfeeding as a community health improvement strategy. And then the next webinar, we're gonna focus on recommendation 2, that is breastfeeding policy systems and environmental change. The last recommendations focuses on the lactation workforce to build capacity of all local health staff. So today, like I said, we're gonna focus on recommendation 1. The full standalone package for recommendation 1 is uploaded on the Blueprint website. Again, you see the link on the bottom. If you just want to see that recommendation rather than the whole blueprint, you can just download that specific one. This recommendation is also represented here in this first circle in our slide template. Each recommendation includes a set of strategies with corresponding rationale, a list of practical implementation tools and other resources, an example of successful implementations. So recommendation 1 states to integrate breastfeeding promotion, protection, and support goals into existing community health improvement strategies, and also integrate lactation support as a component of other health promotion programs. There's a lot to unpack here. We're gonna just provide you with a highlight of each strategy. Each speaker is addressing a few of these strategies too. So this is also the personalized icon package for specifically recommendation 1. All strategies here are critical to intentionally center chest breastfeeding as a public health priority for the community. So the top icons on this big circle here reflects the connection of lactation and health risk reduction. So as such, should be integrated and leveraged with other related health programs that also aim to improve the health of the community. Jolynn will talk more about these connections. Anyways, there are total 6 strategies for this recommendation. Recommendation 1 relates to conducting community assessment to understand the local lactation landscape. Recommendation 1.2 is the inclusion of breastfeeding into community health assessments and community health improvement plans. 1.3 is about educating public health professionals about the connection between breastfeeding and the numerous health risk reductions across the life cycle. Recommendation 1.4, strategy 1.4, integrate the tracking of breastfeeding education and support into performance measure of other public health initiatives. 1.5, collaboration among other organizations implementing health promotion programs to strategic leverage resources. And finally, 1.6 relates to community engagement to strengthen working relationships with partners and community members. So there's a lot. So before we dig into each strategy, let's conduct our first poll about the chat chip, if you understand what chat chip is. So I'll give you a few seconds, so 1 minute to respond. Are you familiar with your community health assessment improvement plan for your county? Okay, I think most of you already responded. So let's close this poll and share the results. It looks like 47% of you are familiar with your community health improvement plan. That's great. Some of you never heard of it. I hope you will look, we'll look and find out more. So can we put the second poll? So for those who know what your CHA, community health assessment or community health improvement plan is, do you know if it includes any chest breastfeeding indicators, goals, or services? A few more seconds. All right, I think we can already close. So it looks like for those of you who knows about your community health improvement plan, 22% says that they have some type of chest breastfeeding indicators, goals, or services. and some don't know. So I like this, 25%. We will find out. Let us know. Thank you. All right. So the inclusion of breastfeeding in the overall community health improvement plan is a pivotal opportunity to improve population health and tackle health inequities. So strategy 1.1 relates to conduct a community assessment to truly understand the local lactation support landscape. This analysis should include breastfeeding rates, availability of services, structural barriers to test breastfeeding, and collect inputs from lactation support providers and families with lived experience to understand how they experience continuity of care in their infant feeding journey. 1.2, strategy 1.2 is to incorporate these breastfeeding indicators into the larger community health assessment, so we like to call it CHA, and then hopefully integrate lactation support as a priority strategy into the community health improvement plan that we call CHIP. If you're not measuring any infant feeding data or services, how do you and others know that you are actually working towards improving breastfeeding rates and also the health of your communities? So those strategies are essential to center lactation support into local priorities. However, without concerted efforts and intentionally planning to tap into lactation support as a powerful strategy, lactation programs and services are often left out of community health improvement plans and priorities and the financial investment opportunities that exist specifically to address the main community health priorities. So let's talk a little bit about this CHIP. So just to give a little context in the world of local public health, if you're not so familiar with it. So let's say you have a health issue in a community that needs to be addressed. It needs to be improved. How does one go about improving overall health within a community? So please bear with me here. What I will attempt to say is a very simplistic way to describe a somewhat complicated, long process. So first and foremost, we have to operate with the understanding that no one single agency or no one single program can actually improve community health alone. This long-term effort requires multi-sector partnership and very, very committed people. Then you need to start understanding what your community assets and gaps are, what health issues are more prevalent and urgent, and what services already exist. Usually every 3 to 5 years, stakeholders come together to conduct a comprehensive CHA or community health assessment or community health needs assessment. So you see on this top vertex of the triangle. So community assessments are essential to understanding the health status and root causes that affect the community. The analysis of the data collected validates the need for funding and informs where priority efforts are needed. So this CHA is kind of the first step of the community health improvement process. So then, as you see on the bottom right vertex here, the how, you see the community health improvement plan, CHIP. That is a long-term systematic effort to address public health problems based on the results of a community health assessment. A community health improvement process looks outside of the performance of a single individual organization serving a specific segment of a community, but instead to the way in which activities of many organizations contribute to the overall health improvement of a community. So all these organizations and community members working together makes up the third vertex of the improving community health triangle. And NACCHO has supported communities to develop their CHIPs for decades. For that, in 2001, we developed the Mobilizing for Action Through Planning and Partnerships, or MAP framework. That is now one of the most widely used and reputable community health improvement frameworks in the field. MAP provides a structure for communities to assess their most pressing health issues. It emphasizes the integral role of broad stakeholders and community engagement and the alignment of community resources towards shared goals. So this is done in collaboration with local health department and many stakeholders, and together they create a stronger infrastructure, align duplicative efforts to maximize efficiency, increase visibility, and ultimately creates a healthier community. Currently, MAP is being updated, but the MAP handbook and resources are free and available for anyone at no cost. So next, we have strategies 1.3 to 1.6, which relates to connection between breastfeeding and other public health areas, and integration of lactation support into other programs, and also integrating the tracking of lactation support activities into performance measure of other public health initiatives. So lactation education and support activities can be incorporated in many other health programs. But of course, not everyone in the local health workforce knows about these connections. For example, connection of breastfeeding, reducing risks of diabetes, for example, or that human milk is a matter of safety and food security during emergencies, as you're gonna hear from our speakers from Jefferson County. So it's important to engage and educate local partners and the public about these connections between breastfeeding and community health improvement. So let's do a quick second poll here to see if you are partnering with folks working outside of the lactation world. So third poll. Oh. This is not really. Okay. Yeah. Are you part of a local health coalition? So that's how you connect to other folks working in public health. So I think we're good. We can close the poll. It looks like you are part of a larger health coalition, so that's great. That means you're probably not working or establishing relationships with folks in other public health areas. Thank you. Okay, so moving on. So research actually has shown that lactation support should be integrated into other services rather than a standalone program. So some of these recommendation on strategies speaks to the critical role of partnerships, especially those with other organizations that implement health programs. So we can work to leverage resources. For example, by co-locating or integrating lactation support within family health and social services, or integration of lactation support services into programs with mandatory attendance, such as the home visiting programs, early Head Start, centering pregnancy, and also inclusion of breastfeeding education into chronic disease prevention trainings and materials for both staff and participants. Finally, the last strategy speaks of community engagement to better co-create programs. And Conectando will talk more about that, but engagement should also include other important people in the community, like community leaders, community organizers, cultural brokers, community health workers. So again, continuity of care only exists if many are involved. Families need different levels of skilled lactation support and other social support at various times through the first 1,000 days. Not one single entity is able to meet all the needs of one family. In this recommendation, we start to talk a little bit about the complex care paradigm, which is a framework that seeks to improve the health and well-being of those who cycle through healthcare, social services, and other systems. Complex care works at the systemic level by creating care ecosystems through local networks of organizations that collaborate to address health and social needs of families together. So just to close this background session, I wanted to show you very quick some examples of what we've been doing here at NACCHO. Currently, we are ending one project, this one in the orange box, called Identifying Care Gaps, and closely relates to recommendation 1. We are also starting a new project, you see in the green box here, with 10 new local organizations that are about to implement some of the blueprint recommendations, and some of them are selecting to implement recommendation 1. I'll talk more about the orange one, orange box here. Hopefully we can talk more about the new grantees in the next webinars. So the Identifying Care Gaps, Conducting Community Assessments to Improve the Chest Breastfeeding Landscape project was specifically and intentionally designed to give organizations time and allocated resources to truly learn the lactation landscape. It is the first grant, to our knowledge, that was specifically focused on assessing the local lactation landscape. Now, we definitely know how important assessments are to inform priorities and programs. So the deliverables here were inspired on the updated MAP process and includes these 3 components: community status assessment, to quantitatively describe the community, so data, right? community partners assessment, so agencies could look critically within their own systems and processes to reflect on their role in advanced continuity of care, and also understand the degree to which they are addressing or perpetuating barriers to chest breastfeeding. Finally, the third assessment was the community context assessment to explore lived experience and historical and structural context for breastfeeding inequities. So on the right, you see the 8 grantees, and they were all required to work in partnerships with at least 2 community stakeholders. We also facilitated some priority identification activities with grantee and partners to brainstorm what to do with all this information they collected now that they have a full picture of their community landscape, right? So we did a very, very, very abbreviated version of the chat sheet specific to chest breastfeeding. As in, grantees and partners conducted assessments. Together, they identified priorities and feasible next steps for the next 2 years. But surely what we're hoping it happens is that all this data collected within the lactation landscape assessment make it to their large community health assessment and hopefully get prioritized in the next community health improvement plans for these communities. So in December, we're going to be uploading all these 8 lactation assessments and resources that they developed into the recommendation 1 of the Blueprint website. Here's another example. Erie County, New York was a former grantee. I wanted to highlight them here so you can see what breastfeeding incorporated into a community health improvement plan look like and how it can evolve through the years. So here they incorporated infant feeding into both maternal and infant health, and also as an obesity prevention strategy. With all this data collected through assessments and planning, they developed a comprehensive process map and goals for the next years for the county. Although I think this is like older, right? It's the last cycle of their ship. So again, I already said that, but without concerted efforts to collect infant feeding data and tap into lactation support as a powerful strategy to improve community health, lactation support services are often left out of community health improvement plans. So this needs to be very intentionally planned. And finally, I wanted to highlight the CDC's REACH program. This program is a perfect example showcasing how breastfeeding is part of a chronic disease reduction and prevention strategy. REACH works to improve community health and end health disparities. So CDC partners with racial and ethnic communities to make healthy choices easier. REACH strategies include increasing physical activity, promoting tobacco-free living, increasing access to healthy foods, and for the first time in 20 years, they incorporated lactation support through continuity of care to prevent and reduce chronic disease. So as I said, we're going to be uploading a lot of new resources to recommendation 1. If you do have any resources that you would like to share for this recommendation or any recommendations, please submit it to Breastfeeding and NACCHO so we can upload and share with the world. So now, without further ado, I would like to turn it over to our first incredible speaker, Jolynn Dowling. I have been admiring her work for a while since I came across the book she recently contributed to, The Lactation, a Foundation Strategy for Health Promotion. This is definitely a one-of-a-kind book. It was written from the public health perspective. And if you're working any side of the continuity of care continuum, this is a must read. I'm so happy that we get to hear her share some of this wealth of expertise here with us today. Jo?
Hi, thank you, Harumi, for the excellent foundation and lead into my presentation. It is really challenging to condense health promotion, community assessment, and community health improvement concepts into such a short time. I was challenged as well when I was writing my chapter on key concepts in lactation as health promotion. And there's just a lot going on in the world and a lot out there that can help inform us in our work. I really feel humbled and honored to have connected with Harumi at the USBC convening this past summer, and through several conversations have learned that we have a lot in common about our approach to establishing community connections to support breast and chest feeding. I briefly want to share my story about what motivates me in this work. My perspective has been influenced through my clinical work for several years as a neonatal nurse practitioner in a level 3 neonatal intensive care unit and an inpatient IBCLC. And then transitioning out of that role to educating entry-level nurses and other healthcare professionals on population health, What I have found is that these students are very eager and interested in the sexy aspects of providing healthcare. And by sexy, I mean the IVs, medications, critical care, surgery, all of those types of technical applications of providing healthcare in the inpatient setting. But they're less interested about strategies to prevent disease, promote health, and keep our population out of the hospital. And this is also evident with much of the focus of lactation care on the technical aspects related to how to achieve a good latch, positioning, assessment of adequate milk supply, and other things. There is less focus on health promotion strategies to support lactation in public and employment settings and our communities where breast and chest feeding people live, work, and pray and play. So when I was contacted by Dr. Suzanne Campbell in 2019 to consider contributing to a textbook focused on lactation as health promotion strategy, I jumped at the chance, as I felt this textbook would fill a much needed gap in the education of health professionals and others on the importance of lactation for health promotion and disease prevention, thereby positively influencing the health and wealth of our communities. So let's get started. I am speaking with you today from Wichita, Kansas. The picture on this slide is of the Keeper of the Plains, which is a 44-foot tall steel American Indian sculpture created by Wichitan and Native American artist Black Bear Boson of the Kiowa and Comanche descent. This statue stands at the convergence of the Big and Little Arkansas rivers. And yes, in Kansas, we say Arkansas rather than Arkansas, and is sacred ground to the Native American people in the area. I come with respect for the land that I am on today and would like to take a moment to acknowledge the Wichita, Kiowa, and Osage people who have and do reside here. While we meet today virtually, it is important to acknowledge the importance of the lands which we each call home and reaffirm our commitment and responsibility to improving our own understanding of local indigenous peoples and their cultures. As I talk with you today, I may be using the terms mother, maternal, woman, or breastfeeding. This reflects the current evidence available and is not meant to exclude LGBTQAI or non-binary people who may be breast or chest feeding. Next slide. Advance the slide, thank you. My presentation will focus on the importance of breast chest feeding as a health promotion strategy, discuss the socio-ecological model of breastfeeding and use of this framework to inform community health assessments and improvement plans, and finish with strategies for partnership engagement to help with successful program development and process improvement. And what I hope you will gain through my portion of this presentation in this webinar is an appreciation of how lactation contributes to the health of the community as an overall health promotion and investment strategy, greater understanding of the importance of breast chest feeding to reduce maternal and infant health risks, and link the socio-ecological model and breastfeeding key indicators to inform community health assessments and also community health improvement plans. Next slide. So why is lactation an important health promotion strategy? Well, simply stated, the return on investment cannot be overstated in terms of improving economies, reducing health risks, and sustaining the environment. Next slide. The current state of the world's health has been impacted by multiple factors, including climate change, natural disasters, acts of terrorism, and emerging disease, which includes our current COVID pandemic. Through all of this disruption, human milk has remained constant as the best source of nutrition as a first food, with the power to make the greatest impact on maternal and infant mortality, as well as world economies. A global increase in breastfeeding initiation, exclusivity, and duration to recommended levels could save over 800,000 lives per year among children ages 5 years and younger. Breastfeeding can improve economies, especially related to healthcare costs. There could be an economic gain of $300 billion in lower and middle income countries if the World Health Assembly goal of increasing the rate of exclusive breastfeeding in the first 6 months to at least 50% were met. The US could save $13 billion per year in medical costs if 90% of families met the recommendation to exclusively breastfeed up to 6 months, and Kansas could save $27 million per year in medical costs. Our current Healthy People 2030 target for exclusive breastfeeding at 6 months is 42.4%. So we have a way to go to meet those potential health savings. I include Kansas as a reference point because I live here, but all of you have the ability to calculate the economic gain to your states as well by using the calculator linked on this slide. Many of the health benefits are dose dependent, so the longer the more exclusive the breast chest feeding, the better. Next slide. Breast and chest feeding reduces healthcare costs through reduction of health risks. Much of this information is probably familiar to you that are attending this webinar, but I feel like it's important to review just the overall impact of the health risk reduction we have on our population. So breastfeeding protects the mother from birth-related complications through the release of hormone oxytocin to enhance uterine involution and decrease postpartum hemorrhage. This oxytocin release and decrease in cortisol decrease the stress response. So when breastfeeding is going well, it enhances the bond between the mother and infant and decreases the risk of postpartum depression. It also impacts maternal health and mortality outcomes by decreasing the risk of breast cancer, ovarian cancer, and protects against cardiovascular disease, including hypertension and stroke. Breastfeeding reduces the risk of type 2 diabetes and protects against obesity. Mothers can return to their pre-pregnancy weight sooner. It also confers multiple health benefits to the infant. And I will say that the health benefits to the infant are well described, and we often are in conversation with our breastfeeding people about what those health benefits are. And we have less of the conversation about what the maternal benefits for health are. Breastfeeding provides essential species-specific nutrition and serves as the child's first immunization. It provides lifelong protection against upper and lower respiratory infection, otitis media, gastrointestinal disease, including necrotizing enterocolitis, which those of you who work in a level 3 or level 2 in ICU where you have seen NEC take a catastrophic stance as far as our infants' lives, it's horrible to witness. Also sepsis, meningitis, UTI, leukemia, neuroblastoma, lymphoma, the list goes on. It is also associated with higher cognition and a decrease in SIDS, type 1 and type 2 diabetes, and also positively impacts weight control through feeding self-regulation, which contributes to a reduced risk of obesity lifelong. Next slide. Human milk is a sustainable food source produced by the human body. It is environmentally safe, it does not require packaging, and does not produce waste. It is always available, warm, and ready to eat. In contrast, human milk substitutes or formula increase environmental resource consumption related to manufacturing, packaging materials, water, fuel, and cleaning agents for preparation, which increases the ecological footprint and pollutants generated in the production process. Next slide. So this is the socio-ecological model for breastfeeding. Many of you are probably familiar with this model. It is a wonderful model that helps guide lactation health promotion by incorporating multiple levels of influence to support the breastfeeding dyad. The recommendation is for infants to exclusively breastfeed for 6 months and then continue breastfeeding with complementary foods up to 1 year and beyond. It is good to keep in mind that the normal age of self-weaning in other countries other than the United States is 3 years or later. This model illustrates the interpersonal relationship at the center of the framework. The levels of influence of this relationship are nested circles extending from peers and family out through the community influence, institutional and organizational influence, and the local, state, and federal policy influence. It goes from the microsystem in the inner circles to the macro system of influence in the outer circles. So when we consider interventions to promote and protect breast and chest feeding within these levels of influence to impact policy, system, and environments, they might include, for the breast chest feeding dyad, a look at prenatal and breastfeeding education, birth plans. Do they include doulas, midwives? Also, do the parents plan to limit visitors after delivery? What about skin-to-skin contact after delivery and beyond? Are there nighttime parenting plans in place? Postpartum follow-up, and also connection with local breastfeeding resources. As we move to the interpersonal level of influence, education and support for partners, fathers, grandparents, and siblings simply can't be ignored. Evidence shows that there's an increase in self-efficacy for breastfeeding people whose partners are supportive. Co-worker sellback is something to consider. If a breastfeeding person has someone in their workplace who has paid time off that's more than what they can use, perhaps they can sell it back to that person so they have an extended leave off work after they have their baby. Also, friends and family taking care of the home, and what I call care of the breast chest feeding person. After the delivery of an infant, we often give a lot of attention to the care of the baby, the infant, and pay a lot of attention to that little person. And we forget to look at the breastfeeding person and the infant together as a system that both need to be taken care of. We cannot leave the breastfeeding person out of the equation of care as we look at our postpartum support. Also, community level of influence, which is breastfeeding friendly childcare providers. What about implementing a breastfeeding welcome here program within your community? Also, La Leche League and other local coalitions that provide breastfeeding peer support. WIC peer counselors, hosting lactation tents at fairs, perhaps implementing public service announcements and billboards to promote breastfeeding, and also lactation rooms in public and employment spaces. At the institutional and organizational level, one can consider maybe interventions targeted toward increasing baby-friendly hospital initiative. How many hospitals in your community or in your state are designated baby-friendly hospitals? Also, baby-friendly physician practices, lactation rooms, obviously, in public spaces can go here, as well as faith community programs to support breastfeeding. Also, the presence of state, federal, and national health authorities or coalitions that support breastfeeding. At the systems and policy level, this is the macro level. These are some interventions that can help support our breastfeeding people, breast and chest feeding people, are parental leave and paid family leave, or employer worksite policy to support breast chest feeding people. What about policies to support parenting students? I know here at my university, we have policies in place to support parenting students as well as our parenting employees. Insurance policy initiatives through reducing deductibles for breast and chest feeding people could be considered, as well as the insurance provision of breast pumps, which is often supplied and has been there since the Affordable Care Act was implemented in 2010. And then breastfeeding friendly airports. We've seen an increase in the airports. Now all airports from small, medium to large should have breastfeeding, chest feeding rooms available for breastfeeding people. Also tracking mechanisms to help evaluate the health impact, because as Hirumi stated earlier, it's one thing to start the initiatives to have these programs put in place, but we need to measure the outcome and the overall health impact that they have on our population of breastfeeding people. Next slide. So how does it begin? It can be really overwhelming to know where to begin. And each community is unique with various resource assets and gaps related to breast chest feeding to support the population. The first step toward change is through community assessment to determine these resource areas. A rural frontier community, which we have several here in the state of Kansas, will have different resources and needs as compared with larger metropolitan areas. It's important for the voices of the community to be included, especially those impacted. So we need to have the people who are breast and chest feeding included in the conversation. Also, just to say, there are various frameworks and strategies to conduct a community assessment. I know the blueprint has several links and tools available to you, but looking through the lens of the socio-ecological model for breastfeeding as each sector is evaluated can be very helpful. Diversity, equity, and inclusion related to people of color and LGBTQIA community is essential for comprehensive assessment. A community assessment evaluates the built environment, which, if you're not familiar with the built environment, is the human-made space in our communities, as well as sectors in government, health and safety, education, transportation, recreation, and other sectors to determine resource assets and gaps. Our experience in Wichita began almost 10 years ago with our involvement in a project to support our local hospital meet steps 3 and 10 of the Baby Friendly Hospital Initiative. And for those of you who are not familiar or maybe can't recall, step 3 is related to prenatal and postpartum education and support. And then step 10 is directly related to community resources and that continuity of care and connections in the community to support breastfeeding people. This was a project through the USBC Continuity of Care Connections, NICCHO Best Fed Beginnings, and administered through our Kansas Breastfeeding Coalition. The first step was bringing together a group of community partners with a shared vision and passion to improve the support of breast chest feeding people in our community. This group included breastfeeding people, lactation support providers, representatives from community organizations that provided prenatal and postpartum breastfeeding support. That included, we have a program called Healthy Babies, as well as WIC, and also La Leche Leg, academia, and others. We were charged with conducting a community assessment specifically evaluating community resources that support breastfeeding. Our work was helped with the fact that there were already a maternal infant health coalition in our community that had developed a community asset map. That using this map along with community dashboard provided through the USBC, we expanded this assessment by surveying the organizations listed to determine what prenatal and postpartum breastfeeding education and support services they provided. We were also able to identify additional community resources specific to breastfeeding through these conversations. So you've already seen the poll and you've already answered the poll, but it was really interesting to me that 60% of you do have a local breastfeeding coalition and 40% of you do not. And so the poll that was deployed earlier was actually supposed to deploy here, but that's just perfectly fine, because what that informs me is there's still 40% of you out there that do not have a local breastfeeding coalition. And we'll talk more a bit about how that can be, how you can develop and partner within your community to form such a coalition. Next slide. So the outcome of the included the forming of the Wichita Area Breastfeeding Coalition, made stronger with the representation of different sectors of the community and not just lactation support providers. And I do want to say here too that we had in the past in our community other coalitions, but these coalitions were only of lactation support providers. And so they form and then they would quickly go away after a project was done or whatever. And so by having different community partners from different sectors of business, law, and other organizations within our community that had a shared interest in increasing the support of our breastfeeding people in our community, then we were made stronger. We didn't just have lactation support providers within this particular group. We also developed a toolkit which included resources to help various community organizations increase their capacity to provide education and support to breast chest feeding people that they served. And we also developed this business card, which is shown here on this slide, to help our breast chest feeding people identify where they could quickly locate resources in our community by scanning a QR code. This is a wonderful example of a low resource, high impact intervention with a long-term positive outcome. The QR code initially linked breast chest feeding people in the Wichita area to a resource asset map that was housed on our Kansas Breastfeeding Coalition website. This has now been expanded to the current breastfeeding resource card that you see here, this business card that links breast chest feeding people in any community in the state of Kansas to the resources in their area. Any breast chest feeding person living in or visiting our state can simply input their zip code into the search window and a lactation resource map pops up with pertinent contact information of where they can go get help and support. It was through this project that our baby-friendly hospital initiative in Kansas was, our first baby-friendly hospital in Kansas was designated, and that was in 2015. Since then, we now, as of a couple of days ago, have 10 hospitals across our state of Kansas that have achieved this designation. I am a strong proponent of coalition building to increase capacity for communities to meet their health improvement plans. Rather than a top-down approach, coalitions start at the grassroots level with 2 or more people and a shared vision and can expand from there. It is about respectful relationships and an awareness to what is already being accomplished in the community. Because the last thing you want to do is come in behind an organization who is already in the space doing the work. This can fracture relationships and undermine trust. Instead, it is helpful to know what is currently being done and build on that work together. It is important for the outcomes of the community assessment to inform the community health improvement plan. This helps redundancy in the work and avoid starting initiatives that may be rejected in the community. Our coalition built several strong relationships, including with our local health alliance, Health and Wellness Coalition, Maternal Infant Health Coalition, and others, as well as the Women's Health Network, the Sedgwick County Division of Health, Medical Society of Sedgwick County. There's several organizations that have come together, and this benefited our community because our coalition was then invited to the conversations to inform our community health improvement plan at a time that our Board of Health was looking to reduce funding for maternal infant health. This community partnership was called the Coalition of Coalitions. So we had several coalitions in our community that came together to really help out our health advocacy, to help our Board of Health make the decision actually not to reduce funding. And as many of you may be experiencing, there's been a reallocation and redistribution of resources, including funding related to the current COVID pandemic. It is imperative that breast chest feeding people and workers be included in the community conversations related to the health assessment and improvement plan going forward. And so I want to ask you at this time to just take a moment and reflect on your current community health assessment or improvement plan wherever you are. What is the community health priority that is impacted by breast chest feeding? You can certainly feel free to input your answers if you would like into the Q&A on the webinar. It would be really interesting to see the diverse answers that might come from what you are doing in your community and your community health improvement plan that breast and chest feeding might impact. Some examples of the community health priorities here in the Wichita area that could be positively impacted by increased duration of breast chest feeding include infant mortality, our diabetes, obesity, unhealthy food options, and environmental concerns. Our last community health assessment was conducted in 2019. There's been some ebb and flow as far as the partners that have been involved with that process. And so my hope is that going forward, we can have a more robust conversation around breastfeeding and the implementation of certain strategies to help impact our overall community health improvement plan that incorporate breastfeeding strategies that are included on the blueprint that has been provided and we're talking about today.
Thank you. Thank you so
Next slide.
much.
Next slide. I just have one more slide. Are we done? Am I over time?
Yes.
Oh,
Thank you so much.
Okay. Thanks, Harumi.
That was
Okay.
a wonderful presentation. You covered so much, covered some of the next recommendation too.
Great. I just had the quote and then my contact information. So feel free to contact me if you have questions.
Thank you so much. I'll turn it over now to Dr. Nandi Marshall. She's representing the Reach Savannah, and they've been one of the Reach rock stars, and you're gonna understand why. So Nandi, welcome.
Thank you so much again for the introduction and greetings to everyone. I'm really honored to be in this space with you all today to share the work that we've been doing in Savannah and Chatham County, Georgia. Having the opportunity to work.
Nandi, just 1 second. Can you come closer? I hear your voice fading a little bit.
Is this better?
Yes.
Okay, perfect. Sorry about that. So having the opportunity to work, I'm still on the first slide. But having the opportunity to work in this arena and really contributing to increasing support of lactation is driven by two things. So the first being my own personal experience with nursing two children, one of whom I was able to nurse for 4 months, started supplementing with formula after 2 months. And then my second child, who I was able to nurse for 15 months. And then additionally, my background, which is using community engagement strategies to address health equity. And with my experiences, I was able to compare in those two phases of my life, my own knowledge about breastfeeding, access to lactation support services policies or lack thereof, and even awareness of those policies, and even my employment status and how they affected my ability to continue breastfeeding my own children. And so additionally, my research and community engagement experiences in Savannah have all been centered through the university of where I am right now, Georgia Southern, and previously Armstrong State University, who has been partnered with Healthy Savannah. And so Healthy Savannah is the lead of the REACH grant that I'm going to talk about now. Next slide. So we did hear a little about the REACH grant earlier, so thank you, Harumi, for providing that context. And with this REACH grant in Savannah, we're primarily focusing on reducing disparities and inequities among African American and Hispanic, Latino Americans in low-income neighborhoods, really focusing on healthy food opportunities, physical activities, and community linkages. When I received an email as one of the community partners of Healthy Savannah to come to this meeting, they wanted to talk about this grant opportunity. And everyone knows the CDC REACH, not everyone, but a lot of folks know that CDC REACH is a really prestigious program and provides really excellent resources to work with communities to find strategies together to improve health outcomes. And so I made it my point to clear my schedule and be there. When we got to the meeting, they talked about sort of what the focus area was or the opportunities for focus on this new grant cycle. And as Harumi mentioned, one of them was this time around the continuity of care and the breastfeeding aspect. And so there were about 2 of us in the meeting, myself being one of them, who were really advocating hard for why we needed to talk about this. We shared information that's being seen at the national level. I talked about my personal experiences, sort of what I shared with you, and then also provided, based on my own experience, here are some things that we can do to really work with communities to identify what's happening here. And so that's how we are here today. And so now I'm going to talk a little bit specifically about what we're doing with the REACH grant in Savannah. So with Savannah Hope, Healthy Opportunities Powering Equity, that's our acronym for our specific project in Georgia. We're focusing on assessment strategies, which will assessment activities, we'll go over some of those today, policy development support, and community outreach. With our assessment, we have 2 phases, one that we've completed, and the second one we just started about a month and a half ago, so this is really timely. I'm excited to talk to you a little bit more about what we're planning to do in the coming year. And so that phase 1 is photo voice, which is the bulk of what we'll talk about today. With our policy development, we're working on workplace lactation support policies and really providing best practices and support in identifying lactation spaces in the workplace and so on and so forth. And then with our community outreach piece, we're looking at that engagement, working on peer support groups, leadership development, community events, recognition opportunities, particularly with our policy initiative and with receiving a proclamation from the mayor of Savannah, which was huge, and then increasing community awareness. And this has been done through PR, media, and other aspects of getting out the word. And so before I start to really dive into our process of photo voice and what our results were, I always just want to take a moment to thank and recognize all of our partners that helped to make this possible. You can see all the logos on the image, but I wanted to specifically point out that purple mother holding baby logo. And so this logo represents the moms who worked with us in our project. We obviously could not have done this without them. Their voices were crucial. And the reason that we wanted to talk to them at all is to hear what's really happening. Like, their experiences are what should be driving what we're doing and not what we read in an article about a state miles away. And so it was really important that we hear what's happening in Savannah and in Chatham County so that we can move forward. So before we go to the next slide, I do want to go ahead and launch the poll for my presentation. Poll, please. There we go. So have you intentionally collected stories of the folks you work with to inform your community practices? So we'll take a couple moments just to get some feedback. And if you haven't, it's fine. You know, we're not here to judge, but this is really the purpose of what we were doing. And so I wanted to see, have you done it before? And this, yes, wonderful. So we have 45% who have, 26 who've never thought about it. So this is an opportunity for those who have never thought about it to maybe consider it and see how it might fit in your work. And lastly, before we move to the next slide, I always have to take time to shout out my baby girl. This is a picture, this is the cover of our final book. And you'll see the link up there. We're going to drop it in the chat. But my amazing graduate assistant, Christina Cook, she created an electronic book. And so that's what that link is. And the cover of our book is my daughter breastfeeding. She's the one I was able to breastfeed for 15 months. There was this amazing Tree of Life campaign a few years ago. And so we participated in it, and we used that for the book. And I'll talk about a little bit why later. So next slide. So with our Savannah Hope Photo Voice project, again, we focused specifically on this project with Black and African American moms in Chatham County. We really wanted to look at some of those issues around continuity of care and really the different levels of which their care was either supported or mostly what the barriers were. And so we did use a social ecological model, and the version that we saw earlier was amazing. It's by far my favorite iteration of the social ecological model. Our focus for this project was looking at physical, social, and cultural barriers. And the results that we received have really been guiding our work. And it's been really excited to know that what we're doing is directly impacting what we heard from the moms that worked with us. So in our next slide, you'll see a very busy slide. And so again, all the slides will be posted, so you'll have an opportunity to go back and look over it. But essentially what this is just our timeline of methods. And so I'm going to quickly just walk you through what we did and how Photo Voice works, especially for those of you who may have never heard of Photo Voice until today. And so essentially we did various recruitment activities around Chatham County with our community partners, particularly those partnered with Healthy Savannah and YMCA of Coastal Georgia. Once folks were recruited, they met with me one-on-one. Of course, we had informed consent included in all of this. We were approved by Georgia Southern's IRB. I met one-on-one with participants just to let them know this is how the process works. Here are the assignments, again, focused on physical, social, and cultural. Talk to them about what it meant. We had these cute journals that they were able to keep track of what they were doing and why they were doing it. We had cameras and tripods available. Some of the moms signed them out. Some moms use their smartphones, which was also pretty cool as well. Once they finished taking their pictures, I met with them again individually, and we went through every single picture they took, and we just had a conversation. You know, tell me what's going on, why you took this picture, how does this represent a particular barrier that you experienced while breastfeeding or nursing your child in Chatham County? And we talked through all of that. Once we got through all of the one-on-one, we were preparing to do a second round of recruitment and to do our overall focus group using the showed method, and I'll speak to that in a second, and then COVID. And so the week that we were planning to go out to start new recruitment and to schedule our face-to-face meeting, our governor shut down the state. And so as you can imagine, it kind of threw us into a panic. One, you know, you're at the point where you're thinking, well, do we continue this? Because, you know, everyone is trying to survive out here. But the moms wanted to continue, we wanted to continue. So we found alternative methods and we had it on Zoom, which ended up still being amazing. I think because we had already built a rapport with our participants and that they trusted us, having a conversation with them on Zoom was great. Once we had all of our data, we analyzed the data, and then I'm going to share now with you our results. So our first set of results, looking at the physical barriers. And so what you'll see on the next few slides are some pictures that were submitted. We have a few quotes and just overall what the feedback was. And there's more data, but for right now, this is what we're sharing to make sure I stay within my time limit so Harumi doesn't get upset with me. So with physical, we had the frequent mentioning of lack of public spaces. And I'm sure that's something that all of you have heard or experienced in your work or heard from folks that you work with. And this includes the continuous recommendation of going to the bathroom. This was happening in churches. This was happening at the bottom picture is a car sales place. The picture in the top right, she had to go in her car because there was nowhere to go in the location where she was. And so one of the quotes that we pulled is that they had bathrooms, but I'm not going to nurse my son in the bathroom. And that's all they had was a bathroom. Moving into social on our next slide, they're talking about, again, this data was collected in 2019, and we're still talking about looks of disgust and disapproval. And so one of the things that we're also trying to do is really show how to support moms and folks who are lactating in this space around the community. And so this is one of the things that they talked about, just still getting those looks of disgust and disapproval. Moving to the next slide with cultural, one of the things that we heard was perceptions that Black and African-American women don't breastfeed. I think this is something that we're still hearing about, even though those of us on this call, we know that Black women and African-American women breastfeed. We know that. Yes, there are still inequities that exist, but we know that it's happening. And so it's really about how we change that conversation, how we change that cultural perception, and let folks know that this is happening. There was conversations about nursing older children. One of our moms, she nursed her child well into age 4 or 5, and she talked about some of the pushback that she would get. And then one that we heard from a few of the moms was specific around nursing around men in their family. And one particular quote, I don't nurse in front of her when there's like my husband around or my dad or any male cousins. I'll go to a separate place. But if it's just me and her and females, then she's cool with it. The she that she's referring to is her grandma. So essentially in her family, if there's a male person around, they do not want them breastfeeding. And so those are other conversations that we can start to have in families. And again, trying to support folks and help them to feel that they can do what they need to do and support their child regardless of where they are. And then on our next slide, this one here, this quote is a little longer, so I'm not going to read through it because I know my time is getting close. But one thing that was also evident with all the moms is that they all told us that regardless of the barriers, something that they had to consistently fight with internally was continuing in spite of their barriers. And for them, that worked. For others, that doesn't work. And so we really need to work harder, work together to get rid of these barriers, because we should not have folks who feel like they can't nurse because of any of these barriers that we've talked about today. In the next slide, we received a few recommendations from the moms. One was increasing lactation and breastfeeding support spaces, but particularly in Black and African-American communities, increasing lactation support specialists. We do have some in Savannah, and they wanted to see more that look like them and have access to more. Increasing peer support group availability, and then more representation of Black and African-American mothers breastfeeding. That last bullet point speaks to a note that I mentioned earlier that really talks about seeing themselves, right? So even if there's advertisement on a bus or a flyer, that they often don't see themselves represented, and they fear that that's not encouraging others who aren't already. And so for the next few slides, we're just going to quickly talk about how this is related to the strategy. And with strategy 1.1, we essentially work through the photo voice piece, right? So that's our assessment piece. That's the piece that really provided us the opportunity on that one. For 1.2 and 1.3, we have the education piece where we're working with some outreach with the one of the baby-friendly hospitals in the county. We were able to get a proclamation. I think I mentioned that earlier. In our proclamation, the mayor of Savannah just basically declared that we are working towards becoming a breastfeeding family-friendly community, which was huge. For the next strategy, we have this really discussion of breastfeeding continuity of care being a part of the conversation around food apartheid, which is being led by Healthy Savannah. So that's huge. Like, we're keeping it in the conversation, and that's just more than I could even ask for. And then finally, establishing additional partnerships for strategy 1.5. We're continuing to work with businesses to create workplace lactation support policies, which again, as I mentioned earlier, is a part of a recognition program. And with this recognition program, it basically says that they're recognizing breastfeeding friendly. They get a sticker, and their names are going to be placed on Healthy Savannah's website. So that's one of the ways that we're working to establish those partnerships, as well as working with some IBCLCs, public health folks, like we're working with our health departments and working with health equity specialists in the area. So that's our quick run through, and this is my contact information. The last slide that you'll see on my piece is just a word cloud that we did that represents some of the most important pieces that came out of our work in the words of our moms. So thank you again for my time, and I look forward to the Q&A session.
Thanks, Nandi. That was impressive. Every time I hear about your project, I learn a little more. So now I will turn it over to our last speakers, Brenda and Allison. There's so many aspects of their project that we can highlight, but today we're currently highlighting that they are granting another project here at NACCHO through the CDC's Division of Reproductive Health, the Building Community Resilience Through Collaboration. So Brenda and Allison, welcome.
Thank you so much, Harumi, and thank you everyone for inviting us into this space today. I'm Allison Wilson, my pronouns are she, her, and Brenda will be able to introduce herself. I'm about to turn it over to her soon, and then I'll come back at the end. So we're sharing this as a team effort with you today, just to talk about community solutions in creating lactation support and safe infant and young child feeding and emergencies plans. So been in public health over a decade, but a decade ago, I wanted to train as a doula, and I think that opened up my eyes to just that stage of life. And then having personal experience, I thought I really want to work in maternal child health if I get the chance to switch from other strategies I was in public health. And I got that chance about 3 years ago within Jefferson County Public Health. That's where I work. And I also live in Jefferson County. So here we are in Colorado with a varied landscape when we think about emergency planning. And I also, Jolynn gave a beautiful description of the importance of land acknowledgement. So I also want to acknowledge that Jefferson County is on the land of the Cheyenne, Arapaho, Sioux, and Ute tribes. And our county is quite large. It's just west of the capital city of Denver, 550,000 people. 11 municipalities. We have urban areas as well as starting to get right up into the mountains. So just a lot to think about in reaching various communities and planning for emergency preparedness. Okay, you can go to the next slide. Just a really quick snapshot, and I think this matches what we've all heard already today in a lot of ways. But specifically in our state, I think I've got our birth rate. You can keep clicking through. They will pop up as you click, I believe. Today, you're going to hear from Brenda around our Latinx leaders and what they've been coming up with as solutions and ideas for stronger lactation support. So in our state, we have about 20% families identified as Hispanic, that those 6,000 births annually. That's how our data breaks down. As others have mentioned, we have high initiation rates of chest breastfeeding, and we do see that across all of our communities and all income levels. When we look at our breastfeeding report card, our state data, some of our local data, we're trying to do a better job of collecting that, and as well as our WIC data. But then, as others have mentioned, we do see that decline, and it's especially apparent even more so among our communities of color and low-income families. And we know that's effective systemic racism, historically under-resourcing in those communities. And as I know just others have shared, we've been trying to hear from the community, and Brenda will share more, but similar stories of, it's not enough that someone is bilingual and giving me lactation support. They still aren't of my community and don't know us and can't truly provide that culturally congruent care. So I'm going to turn it over to Brenda to share more about how our Latinx leaders with Conectando brought forth solutions, were really how they wanted to own what lactation support would look like. So thanks, Brenda, and I'll be back in a bit.
Hi, thank you, everyone. My name is Brenda. I'm a registered dietitian and lactation consultant. I work with the community for over 9 years. 8 years of those were with the WIC program. And during my work there, I noticed that a lot of our Latinx community was really lacking a lot of resources, especially breastfeeding, since there is not a lot of lactation consultants who speak Spanish, let alone native Spanish speakers. And in 2018, there was Adelante was formed, and it was a partnership between Jefferson County Public Health, Jefferson County Public Schools, Jeffco Library, and Colorado Statewide Parenting Coalition. And they invited me to teach a nutrition class for our Latinx family, friend, and neighbor providers. And that's how I became part of Conectando. Later this year, we changed the name to Conectando because it reflects what we currently do with the community, which is connecting our Latinx families with different services and resources. And during this time, in my part, if Conectando has really been wonderful because, like I mentioned before, I work with public health, but I never felt as empowered as when I'm with Conectando because I can learn from my community and we can all provide different ideas and no one is saying, oh, we cannot do that. Instead, we said how we can do it. Let's figure out a way how we can work together. And this has been successful because Conectando uses the community-based participatory research principles, where there is not only one leader, but rather all of us are leaders. All of us make decisions. We create our strategic goals. And we have different leaders already in the community per se. I was part of public health, so some of the members were paid, and most of them were volunteers. And also some of them were already working with the community. We have a lady, Xiomara, she was working with children with special needs, and she already had her group. And so Conectando is a way that a lot of us in Latinx, we can share our culture because all of us speak Spanish and everything is based on providing culturally appropriate services in the community. And some of the areas we wanted to focus on, and one of those was breastfeeding. Next slide, please. And so we created a group of consejeras or breastfeeding counselors, and it started in January 2019 with 24 participants. And we focused mainly on the family, friend, and neighbor providers because they are in PASO curriculum where they are providers advancing school outcomes, and they're gonna learn more principles for early childhood education that they can apply to the children they are taking care of. And during that time, we talk about the breastfeeding friendly certification. And out of that, we created some promotoras in March 2019, where 18 FFN providers got breastfeeding friendly certified, and the consejeras who were helping with that certification got paid. And then the picture that you see there is the first meeting we had in January 2019. Next slide, please. And in May 2019, that's when we started to get more education together. We're a total of 14 people in the group, and we are part of USBC, and we all have different specialists. Like I said, I'm a lactation consultant, but they are members of the group who are, we have a doula, a nurse, and other people working with different community programs. And also we have family, friend, and neighbor providers who are already working with the community. And during this time, since we all have different backgrounds, the nice thing about it is that we all take the same training together, and we share our experiences and knowledge with each other. So when we started, we took 16 hours of lactation counselor training, focused on how breastfeeding is affecting the community, and especially the Latinx community. We also had some lactation friendly certification training, and infant and young feeding and emergencies training. And Alison will talk more about that. We also had training about communication and leadership, where we were able to learn how to take care of projects and be able to work more with the community. We also took infant and maternal mental health class, where we invited some of the FFN providers there. And last month, we finished the Community Lactation Access Project. And the nice thing about that is we have simultaneous interpretation there, and we're helping try and create some of the trainings. And like I mentioned before, we all get together and decide what projects we want to work on, and that's how we offer a prenatal class. And we have breastfeeding support group, and we also have a phone line that people can call if they have any questions about breastfeeding, and all of us take turns leading the groups or answering the phone calls so that we can get more practice and use those hours for either the CLC or IBCLC certification. And during this time, during COVID, we are doing these virtual breastfeeding support groups, and we have people from different areas of Denver and even from Mexico attending those virtual support groups. And a lot of our consejeras are part of the food. They help distribute food to the communities and all the resources for our families. And we still continue providing information and resources for our family friendly neighbor providers, especially the breastfeeding friendly certification.
Thanks so much, Brenda. I just have a few more slides to share about our safe infant feeding work. And Erica, you're welcome to do the poll now as well, if you would like. So as Brenda mentioned, it was really amazing that we were able to hear these ideas and solutions from Conectando. And it was really nice synergy because at that same time, we were realizing we had a gap locally around supporting safe infant feeding in emergencies. So I'm just going to very quickly share what we did on a local level. And now we are hoping to expand it statewide. So the poll talks about what plans do you have in place? And it looks like most folks, 73% are not sure. A few have a formal plan or an informal plan. And honestly, that's really where we were in 2018 with the not sure, and then realized we don't have a formal plan or any plan in place to be able to support this. And we saw that as a gap, thanks to our friend and colleague, Paulina Erices in our maternal child health team at the time. And also Christine Billings was our emergency preparedness director, and said, let's really try to bridge this gap and figure out how we can support this population. So we first worked on creating a written plan, and we'll share a link to our Google folder. So I'm going to try to keep this a little bit briefer, but we created a written plan that lives in our emergency support Function 8 plan. So when there's an emergency, we're automatically integrated as a resource of support. We then, it was great timing to train volunteers, and this was the same time that Conectando was developing their lactation counselor trainings and vision. And so some of those leaders were able to be part of our first 2 volunteer groups trained. And these are volunteers trained specifically to support families in an emergency with any feeding needs. So we had them co-create our training with us. I do want to mention too, we learned a lot from partners everywhere that are working on this, especially Puerto Rico and New Orleans. But we held these trainings with simultaneous interpretation. Anyone attending just really needed to have some existing skill set with supporting families in feeding, as we were just helping them then apply that in an emergency setting. So we have quite a variety of skills within our existing volunteer group. And the volunteers also really helped us think about what supplies might be needed in an emergency. So currently we have 30 volunteers, and then we developed these individual family kits that's on the next slide. Ready to, on the left, there's a smaller family kit that can be given to any family that has a child age 2 and under in an emergency that's receiving human milk or breast milk substitute. And then we also worked on creating larger shelter bins that would then be deployed to a shelter that the volunteers could then pull from when you'd have specific needs in a family, such as say a breast pump is needed, or maybe there's a need for a stove for proper cleaning of supplies or heating water to prepare breast milk substitute appropriately. So they helped us kind of get our plan ready locally to serve both Jefferson County and also our 10-county region around us. We're fortunate there's already sharing of resources in that 10-county region when it comes to emergencies. You can go to the next slide. And it was really key when we started this process that we first talked to our emergency response operational managers, and we went to one of their existing meetings where it's folks from all these 10 counties that are in emergency preparedness. And for us, and what we learned from others as well, we framed it as this is a vital safety issue when it comes to emergencies. It's a pediatric disaster planning gap, and we have an idea for a solution. We don't expect you to be lactation experts, but we can offer you this project where we would have volunteers and supplies that can be deployed as needed. And they were really receptive to that, and just framing it, the importance of that. And we held a webinar, a follow-up webinar with them as well to get their input. I'll keep this quick because I just want us to still have a little time for Q&A. I just wanted to show you our current structure. Oops, sorry, if you can see on that slide. We have the ability, so like say I would be the lead in incident command, I get all the information about the emergency happening, and then we can send out our volunteers in these teams of 3. And we had set up our training thinking about in-person deployment to a shelter, but now we're obviously recognizing from the pandemic, there's been a lot of adaptation with virtual support. So we are starting to think about other ways that we can integrate our safe infant feeding work. Okay, go ahead. And then just to share very briefly, we were fortunate to get the NACCHO award this year, as Harumi mentioned, around building resiliency between maternal child health and emergency preparedness. That's just given us a chance to focus in on something we always visioned and wanted to do, which was to make sure this could be a statewide program. And we've been having new meetings. We've talked to our volunteers throughout the pandemic. As Brenda mentioned, Conectando did some amazing adaptation around virtual support, food security, first food support, what does safe infant feeding look like at food shelters, and donations. And now we are partnering too with our Medical Reserve Corps, which is going to be an amazing asset to really help us take our local plan, and it's going to become a statewide mission ready package so that it's going to translate into where emergency response managers understand how to order a mission ready package. And our Safe Infant Feeding project will be able to hopefully be that by next summer and available statewide for use. So just wanted to say, last slide then, thank you. Gracias, thank you. Again, as others have mentioned, we without our Conectando community leaders, we wouldn't have the depth or reach of where we are today with our work in lactation, and really just hearing their solutions and figuring out how we can dedicate and move funding out to them rather than expecting them to change for what funding is. So we're really trying to do better at that. And you can find Conectando on Facebook. They're doing a lot of other things outside of lactation in the Latinx community here. And then we'll share our Google folder link if you want to look closer at safe infant feeding materials.
Thank you. Thank you so much, Brenda and Allison. Y'all continue to amaze all of us here at NACCHO. I can't wait to see the final results of this current project. We don't have a lot of time for Q&A, but we're going to turn into Q&A. So if you can come back and turn your cameras on for at least 1 or 2 questions. This is the next webinar, February 22nd on recommendation 2. You can pre-register. So we're going to start the Q&A, but first I wanted to share this. I'm going to leave the slides here, and the links will be popping up in the chat box, but there's different processes to get CERPs and CDC continuing education. So I'll just leave it there. And I'm going to just get us kicked off with our Q&A. There's a lot of questions about templates for community lactation assessments. So I would recommend that you check the Blueprint resource list, because there's a lot. Nandi shared her photo voice project, but other REACH recipients also conduct some, and we added those there. If you still need more resources, please reach out. Someone is asking about continuity of care in early care and education, and I would highly recommend that you come back on for the next webinar. We're going to have the early care and education continuity of care toolkit highlighted, so would definitely come back. Now I would like to get a question for Nandi. Someone's asking that for you to speak more on recently racial historical trauma and breastfeeding, because a lot of Black women are afraid to breastfeed in front of other Black women and not only Black men. Can you comment on this? Have you heard this? Did that come up in the assessment?
Sure. So I did go ahead and type up my response. So just in case the person who asked didn't see it, one of the things I wanted to make sure I mentioned was for our participants that were in our study, it was really their female elders who were uncomfortable with them nursing in front of others. It wasn't them. And so that was very interesting. But one of the things that I was thinking that the presentation they heard could have been speaking about was there's a lot of discussion and studies and books written even about perceptions of and connections to objectification of women and breasts as a remnant of the wet nursing era during slavery. And so that could be one thing why people feel uncomfortable. But for the purpose of our study, I just wanted to make sure that it was clear that we didn't see that, but that doesn't mean it's not happening. But there are some other qualitative studies out there that have talked about that uncomfort level.
Okay, thank you, Nandi. So we are at the time. What we're gonna do is we answered some of the questions specifically to the person that asked the questions, but we're gonna put a Q&A. We're gonna compile all these questions and send with the recording of this webinar to everyone. So just thank you so much for being with us today. I know that was a long webinar, especially after 2 years of pandemic. So just thank you, we really appreciate, and I hope you learned a little bit of everything on recommendation 1. Thank you for the amazing speakers, really appreciate you. And everybody have a great end of the day and end of the year. Thank you.